Good evening and welcome you all to the last presentation in basic modules organized by the Federation of Clinical Pharmacists in India. I'm Dr. Alia Salim, clinical pharmacist at Apollo Cancer Center and Infectious Disease Forum member of Federation of Clinical Pharmacists in India. So with this, we'll come to a conclusion in the basic modules in infectious disease in 2023. Next set will be starting in 2024. So stay tuned for that. So we have some exciting ventures. So before that, I would like to go through the participation guidelines, which is all same for everyone. A slide. Yeah, for participants, you can post your questions in the comment box below the video thumbnail, and these questions will be discussed at the end of the session. You have to submit your feedback form, which will be made available towards the end of the session. Only then you will be able to download your certificate if you complete and send the feedback form. Next. Yeah, you can get your certificates within 10 days after you submit the feedback forms. And all this basic modules until today will be made available in our FCPI official website. So you can download it anytime from the website. So, and if you have any doubts or queries, you can feel free to reach us out at FCPI official website, or you can mail us at fcpiofficial@gmail.com. We have some exciting ventures that are ahead of us, starting with our CP Conclave, which will be held in the November. It is organized by Amrita in collaboration with FCPI. Next is our CP Summit, which is held in November. It is organized by Indian Pharmaceutical Association of India and in collaboration with FCPI. It will be held in Pune. Next is a ID Congress 2024, organized by ICRA International Hospital in collaboration with FCPI. So without any further ado, I would like to welcome our speaker, Dr. Ajmal Karmarakuri. He is PharmD in BCIBP. He's a clinical pharmacist with a strong focus on clinical research and antimicrobial stewardship. He completed his PharmD from Al Shifa College of Pharmacy and has been since contributing his expertise to Everett Health Services in UAE. I would like to mention the topic for today is therapeutic drug monitoring of antimicrobials. Welcome you, sir.
Thank you, Dr. Alia, for inviting me. I hope I'm audible.
Yes, sir, you're audible.
Good evening, everyone. So today our topic of discussion is therapeutic drug monitoring of antimicrobials. We know that we had many valuable session last few months on antimicrobials, and I thank all of those faculties and presenters for the wonderful sessions. And this will be the last session on the antimicrobial for this basic module. So what is therapeutic drug monitoring or TDM? TDM is a measuring of specific drug level at a designated interval to maintain the desired or constant concentration of the specific drug in the bloodstream. So it is used for optimizing the antibiotic dose and the interval. So the purpose of TDM is to maximize the efficacy and to minimize the toxicity by the specific antibiotic. So why we are doing therapeutic drug monitoring? The purpose is to individualize dosing therapy for each patient and avoid toxicity, assessing the compliance of treatment. Then if there is any failure of therapy, to check that, and patient clinical status, and if there is any drug-drug interaction, and to guide the withdrawal of treatment and discontinuation of antibiotic. So as we know that this is the basic plasma drug concentration time graph. Once we any medication or any antibiotic in specific, we give into the bloodstream through any IV or oral route, it get absorbed into the bloodstream, and at a particular level that is called the minimum effective concentration, it start producing its pharmacological effect. Then the absorption will continue, and the level of drug in the blood also continues to increase. And at a particular point, it is reaches the peak level. In that level, the rate of absorption and the rate of elimination will be same. So in therapeutic drug monitoring, we are checking the peak level to check whether the peak level within the therapeutic index. In the graph, it is mentioned at the top of this the point is called peak level, and then the elimination rate of elimination will be increasing, and at a particular point the level of the drug in the blood will be reaching again back to the minimum effective concentration. That is called the trough level. So in that point we have to do the next dose, that is called the redosing period or the trough concentration of the drug, because below that trough concentration the drug will not be pharmacologically effective. So this is how we decide the interval for each medication and each antibiotic. So this is how peak level and trough level is important to maintain the level of the drug within the therapeutic index, to avoid toxic concentration, and to avoid subtherapeutic concentration. So this is what happen if we are giving the dose inappropriately. This graph become like this. In the graph here, you can see if the dose is too low, it will not reach the therapeutic concentration. It will be less than the therapeutic level. If the dose is too high, it will be more than the toxic concentration. It will be harmful for the patient. If the it also depends on the patient's rate of elimination and infrequent dosing, and if there is a more frequent dosing, all these kind of things will affect this plasma drug concentration time profile, and it will be inadequate, and it will, or sometimes it will be toxic to the patient also. So that's why we are concentrating on therapeutic drug monitoring. So these are the major antibiotics requiring TDM, including vancomycin, then aminoglycosides, teicoplanin, chloramphenicol, then antifungals such as itraconazole, voriconazole, posaconazole, etc. Mainly, we are doing TDM for vancomycin and aminoglycosides. It depends on the facilities. Some hospital will have facility option or the facility for doing other antibiotic as well. In my current hospital, we are doing for vancomycin and aminoglycosides. So these are the factors affecting therapeutic drug monitoring. This is in general for all medication or all antibiotic. Drug-related factors include narrow therapeutic index drugs, significant pharmacokinetic variability, then a reasonable relationship between plasma concentration and clinical effect, then the concentration range and cost effectiveness of drug assay. That means the cost of the test also have a role in that. If the patient can afford or not, it is also affecting the TDM. Patient-related factors including drug-drug interaction, toxicity, treatment failure, and non-compliance to the treatment. So when to take the sample for TDM? In general, in most of the cases, we take the sample in steady state. Okay, then earlier we check the TDM earlier if there is any toxicity or kidney injury, something like that, if suspected. So generally measured at the elimination phase of the drug, we are checking that is called a trough concentration. As I already said, it is measured at the elimination phase of the drug. Peak concentration is also checking for not for all antibiotic, for some kind of antibiotics such as vancomycin and aminoglycoside. So one important part for the therapeutic drug monitoring is what to document. So once the physician order for the therapeutic drug monitoring, like trough level or the peak level, the like time of the sample collected is very important, and it should be documented in the patient profile, and the time of dose given, then the dosage regimen, patient demographics, co-medication, and other comorbidities, and what is the indication for doing this TDM. All these kind of things should be documented, because based on this we will calculate the like area under the cover, for the example in case of vancomycin. So these informations we required for calculating this TDM. So before making dose adjustment based on any like trough level or a peak level, we have to consider a few things. If the sample was taken at correct time with respect to the last dose, or if the steady state has been reached, if patient is adhere to the treatment, if there is any drug-drug interaction, or if there is any liver or kidney dysfunction, and there is any pharmacokinetic variability such as poor bioavailability, rapid or slow elimination, or there is any drug-drug interaction. All these things we have to consider before making a dose modification or modification in the current regimen based on the trough level or peak level. So first, we will discuss about aminoglycosides, which is one of the most commonly used antibiotic, and we are doing the TDM for this antibiotic very commonly. So we know that aminoglycosides are concentration-dependent antibiotics, and they bind to the 30S ribosome, basic mechanism of action of aminoglycosides. They are mainly gram-negative, covering the gram-negative bacteria, but they have some gram-positive effect against staphylococci. So we are giving as a gram-positive synergy along with it's a combination treatment. For example, in infective endocarditis and all. Serum peak level for efficacy and trough level for toxicity, we are usually monitoring for the aminoglycoside. So how we are determining the dose for aminoglycoside? We are using the total body weight if the patient is underweight or non-obese, but we have to calculate the adjusted body weight if the patient is obese. If the patient is like obese, we cannot depend on the total body weight. It will be overdosing. So we have to calculate the adjusted body weight using this equation. So another thing is that we have to calculate the creatinine clearance, and according to that, we have to adjust the dose. If the kidney function is normal, we can go for the full dose. Otherwise, we have to adjust the dose. We will use the Cockcroft equation for the creatinine clearance calculation. So for aminoglycoside dosing, we have two methods. Two kind of dosing is generally recommended. That is high dose extended interval dosing and conventional or traditional dosing. So first we will discuss about the high dose extended interval. That means once daily dosing. Nowadays, the newer guidelines generally recommend to go for high dose extended interval dosing because the three main factors. Because one is aminoglycoside is bactericidal activity generally depend on the concentration of the antibiotic. This is not a time dependent antibiotic. This is a concentration dependent antibiotic. So if we give high dose as a single dose, it will be more effective. Then second thing is aminoglycoside exhibit post-antibiotic effect. The third point is that higher peaks do not generally risk the like increase the risk of toxicity. So this is why high dose extended interval. That means a full dose for one day we are giving as a single dose instead of divided dose like 2 times or 3 times. So there are some exclusion criteria for high dose extended interval therapy. If the patient is renally insufficient, or if the patient is pregnant, or there is if the indication of the treatment is gram-positive synergy infection, then if there is ascites or burns, these are the exclusion criteria. In all these cases, like we cannot go for the high dose extended. We have to go for the traditional 3 times or 2 times daily dosing for the aminoglycoside. So in order to do the like high dose extended interval dosing, we have two nomograms. Nomograms in the sense like we are talking about the therapeutic drug monitoring. So we have to monitor the level of once we started the like gentamicin or tobramycin or amikacin, we have to check the level. So there are two nomograms generally recommended. One is Hartford and the other one is Urban Craig nomogram. So I will discuss about Hartford nomogram. In this case, if the dosing is 7 mg per kg for gentamicin or tobramycin, or in case of amikacin, if it is 15 mg per kg, we depend on Hartford nomogram. I will discuss one example to get a clear picture about it. So initial level, once we start the dose, we will check the initial monitoring 6 to 12 hours after the first dose. Then we will use the nomogram to modify the dosing interval based on the level we got from the sample we send after the 6 to 12 hours of the first dose. So in case of amikacin, we divide once we get the level, we divide it into half, then we plot on the graph. This is the Hartford nomogram. In this case, this is the time between the start of infusion and sample draw, and this is the concentration we receive from the lab. This is the level of the drug in the blood. So, for example, if like the sample is withdrawn 7 hours after the start of infusion, then the level came as 6, or for example 10. If the level is 10, it means if we plot on the graph, it means it is not comes under the Q24-hour interval. That means we have to modify the dosing interval from Q24 hours to Q36 hours, because the drug is getting accumulated in the blood more than desired. So this is how we use the nomogram to adjust the dose of the drug based on the level of the level in the blood. The second one is urban Crab nomogram. In this case, if the dose of gentamicin or tobramycin is 5 mg per kg, the previous one was 7 mg per kg. It was a higher dose. In this case, if the dose is 5 mg per kg, we depend on the urban Craig nomogram. If it is amikacin, the same 15 mg per kg per dose. Once we start the antibiotic, we will withdraw the blood sample to monitor the level 6 to 12 hours after the first dose. Then we will use the nomogram to modify the dose. Same as previous method, we have to divide for amikacin. We have to divide the level into half before plotting on the graph. This is the urban Crab nomogram, same as before. Like we have to check when the sample was withdrawn from the infusion starting end of the infusion. Then like correlate with the concentration we get from the lab. Then if it is coming appropriately, like if we are giving Q24 hours dose and the level in the graph also coming in the same region, it will be, we can continue the same. Otherwise we have to modify according to the nomogram. So therapy modification, if the random level falls within the area, yeah, like I said, we can continue the same dose. If the falls level on the, if the level falls on a line, we have to use the higher dosing frequency, not the lower one. So if it is falls above like Q48 hours, here the maximum is Q48 hours. So if it is falls about that, we have to discontinue the current regimen, and we have to think about traditional dosing instead of extended interval dosing. So if the random level we check, if it is undetectable, if the lab report says the level in the blood of is undetectable, we have to switch to traditional aminoglycoside dosing. So follow-up trough level, like once we check the level and adjust the dose and optimize the therapy, then we have to do the follow-up trough level. If the patient is having any acute changes in the renal function or any treatment failure, or maintenance, random level should be maintained at least once weekly. We have to do otherwise. If the duration of the antibiotic is more than 2 weeks, we should perform audiometry, because aminoglycosides are like ototoxic. This is one clinical scenario, how we check the, how we use the nomogram. I will just read the case. PP is a 66-year-old woman who undergo CABG 8 days ago and has been on ventilator in ICU since then. Her temperature is now rising, and the chest radiographs reveals new infiltrates in the right lower lobe. She is now started on cefepime plus gentamicin and linezolid. So we have to focus on the gentamicin dose. The patient body weight is like here we are using 7 mg per kg. So we have to 60 kg. So 7 into 6, 420 milligram. This is the empirically we started on this dose. So since the dose is 7 mg per kg, we will follow on the like Hartford nomogram. So the gentamicin level was withdrawn 10 hours after the first dose, and the result obtained was 4 mics per ml. So from the lab, we get the result 4 mics per ml, and we know that the level was withdrawn 10 hours after the start of first infusion, and the dose of gentamicin is 420 milligram. So what we will do, we will plot this information on the Hartford nomogram. So these are the answer choices. We have to choose the correct answer. So this is how we get into the answer. Here you can see we 10 hours after the infusion, we take the sample. So in the x-axis we go for the 10. Then the concentration obtained was 4. So we will just, if we draw a line to the 10, it will be within the Q24-hour range. So what is the current regimen? Is gentamicin 420 milligram IV Q24 hours. So it means we are giving the appropriate dose. We are not giving any overdose or underdose. So this is how we are using the nomogram for extended interval dosing for aminoglycosides. So the other method for aminoglycoside dosing is conventional or traditional dosing. So traditional dosing means we will give a loading dose, then 1.7 mg per kg Q8 hourly for gentamicin and tobramycin. Case of amikacin, the dosing will be different. So mainly we are giving this for gram-negative infection. So as I said, the initial dosing will be 3 mg loading dose 3 mg per kg. Then the maintenance dose will be 1.7 Q8 hourly. For amikacin, it will be 7.5 mg per kg loading dose, then 7.5 mg Q12. It will vary, depends on the clinical condition and the renal function of the patient body weight. All these kind of things will affect dosing. So for traditional dosing, we will check serum peak level and trough level. So first peak level and trough level, we will wait for the steady state concentration to achieve. We will not check the level from the first dose. We will check at least fourth maintenance dose. So the trough level immediately before the fourth, like 30 minutes before the fourth dose, we will check. And peak level half an hour or 1 hour after the fourth maintenance dose. Like two level we will check. One is just before the fourth dose, and the other one is after the peak level after the fourth dose. So in case of dialysis, we will go for pre-hemodialysis. We will go for pre-HD level. In case of CRRT, it will be 24 hours after the dose, and in case of peritoneal dialysis, 48 hours after the dose. So this is how we interpret peak and trough in case of traditional dosing. For example, there is variability based on the infection type, and if the desired peak level is also for gentamicin and tobramycin will be like 7 to 9 or 5 to 7 in gram-negative infection, like non-severe infection. And if the indication is for gram-positive synergy, it will be a little bit lower, 3 to 5. And for amikacin, the level usually it is 25 to 30 or 20 to 30. Like this table, we can depend on that. And for the trough level, usually the recommended trough level is less than 2 in most of the indications. So this is already I discussed in case of hemodialysis and peritoneal dialysis. We are checking pre-dialysis for hemodialysis. This is called pre-dialysis level. Based on that level, we will optimize the dose after the dialysis. So when to obtain the follow-up level every 3 to 5 days to ensure the dosing interval is still appropriate. And if there is any renal function suddenly deteriorate, we have to check more frequently. So this is how we go for the therapy modification based on the trough and peak. Already we discussed about that. Either we will modify the dose, increase the dose, or decrease the dose. Otherwise, we will go for changing the dosing interval. Like if we will increase the dosing interval, it will have an effect based on the trough and peak. So the next important antibiotic here we are discussing is vancomycin. Vancomycin, like we know that it's a tricyclic glycopeptide antibiotic. It's active by inhibiting the cell wall synthesis. So usually we are giving as intermittent infusion and sometimes in continuous infusion also. So usual dosing is 25 to 35 mg per kg loading dose, and the maintenance dose typically 50 to 20 mg per kg every 8 to 12 hours. All these basic things we know already. So we know that same like aminoglycoside and gentamicin and amikacin, vancomycin is also nephrotoxic. So it is highly recommended to monitor therapy, TDM like peak and trough. This graph is very important because this is discussing a new term called area under the curve. Because now the newer guidelines recommend to go for area under the curve, that is called AUC instead of trough and peak alone. So this area under the curve will give you accurate level of the blood vancomycin in the blood, and it will help you to optimize therapy more appropriately. So trough level monitoring. This is the traditional method of monitoring the vancomycin that is called trough level or random level monitoring. It is mainly recommended in case of dialysis. This is like newer guidelines says only in case of dialysis or if the patient is having any CNS infections such as meningitis or ventriculitis. In that case, we don't recommend AUC or area under the curve monitoring. We recommend trough level, the traditional trough level monitoring itself, because the reason behind is some evidence highlights that the trough guided dosing is associated with higher likelihood of AKI, like kidney injury. Like trough level monitoring, we will be giving the patient sometimes more than the expected dose. It will be overdose that will maybe sometimes lead to kidney injury. So if the what we will do if we have a patient on dialysis or the patient have a CNS infection, in that case we will go for the trough level itself. We will not go for AUC monitoring. So in that case, we have to check the trough sample 30 to 60 minutes prior to the next dose, like next fourth dose or the third dose. For dialysis patient, the sampling time for trough is pre-dialysis, just before the dialysis session start. Usually in our practice we are taking the sample for a dialysis patient from the dialysis unit. Otherwise it will be too much early, so it will be we will get a wrong result. So this is the trough level target for it is there is a variability based on the indication. For meningitis and ventriculitis, the preferred target is 15 to 20 mg per ml. And in case of non-severe infection or non-staph aureus infection like UTI or cellulitis, it will be 10 to 15 mg per liter. Then in case of dialysis, it is 10 to 20. If severe infection and dialysis, it will be 15 to 20. So this is how we modify the dose based on the trough level. If the trough level is more than the trough level goal, we will just either we will hold the dose or we will reduce the dose or we will increase the dosing interval. Or if the trough level within the trough level goal, we will keep the same dose. If the trough level is less than the trough level goal, we will maybe increase the dose or decrease the dosing. Like we will more frequently we will administer the dose. In case of dialysis also, like I said, based on the trough level, we will modify the dose. Post dialysis dose, usually we are giving post dialysis for vancomycin. So another important thing we have to consider during vancomycin therapeutic drug monitoring is administration time. There is high chance of wrong sample time and documentation error happens during vancomycin therapeutic drug monitoring. In my clinical practice also, we face many times error happened. Like if we don't communicate properly, it will lead to error and the sample will be taken at the wrong time. It will give you wrong result and the cost of the test will be high, not like say, a regular blood test. So the patient will bear the cost, unnecessary cost for wrong result, wrong lab test. So we have to communicate with the physician and the nurse to make sure the order is correct, the time of sample is correct, and everything is documented appropriately. So physician shall place trough or peak level order and specify the sample time with respect to medication administration time. Okay, as we know that trough sample we are taking 30 minutes before the fourth or third dose, and peak level 1 hour after the end of the infusion. Like if we are giving dose over 2 hour infusion, we have to wait another 1 hour to take the peak level sample. All these things they have to document also. And another important thing regarding vancomycin is the vancomycin infusion rate. The infusion rate is very important because if we are giving a faster rate, it will lead to Redman syndrome. It was previously called as Redman syndrome. Now it is called as vancomycin infusion reaction. So we have to like optimize the infusion. Maximum speed should be 10 mg per minute. Like if the dose is 1 gram, it should be over 100 minutes or 2 hours. For pediatric patient, we have to maintain at least 1 hour because the dose will be like 300 milligram or 400 or 500. So we have to give at least over 1 hour or maximum 10 mg per minute, minimum 1 hour for pediatric. So after the dilution for vancomycin is also important. The vancomycin once diluted, the final concentration, standard concentration is 5 mg per ml in normal saline or ringer lactate. If the patient it is suppose if the patient has no fluid restriction or any renal impairment, If there is any like fluid overload, there is any fluid restriction, we have to go for maximum 10 mg per ml. So as I already said, the nurses shall document the start time and the end time of the infusion. This part is very important when you are doing that therapeutic drug monitoring. So the next important thing is AUC guided monitoring. Already we discussed about trough guided monitoring for vancomycin, and we discussed about what are the indication for trough guided monitoring. All other clinical condition we are going for AUC guided monitoring because it will help to avoid any side effects such as acute kidney injury. So the target area under the curve for vancomycin is 400 to 600 mg/hour per liter. So if like empirically, if we are starting, we will not have any MIC for vancomycin. Once we get the culture report and we have the MIC, so we have to check the vancomycin MIC is less than 1 mg per liter. If the MIC is more than 1 mg per liter, there is high chance of treatment failure if we are following the AUC guided monitoring. So AUC guided monitoring recommended for serious or confirmed staph aureus, example MRSA or MSSA infection. MRSA infection. MSSA we don't go for vancomycin. Then AUC monitoring, there are some exclusion criteria for area under the curve monitoring. We will go for that, like as already I discussed. If there is any kidney injury or rapidly fluctuating renal function, we don't go for AUC monitoring. Then if there is any patient is on dialysis or the patient is having any suspected or diagnosed confirmed CNS infection, we will not go for AUC monitoring. The concept is that AUC monitoring usually patient will receive a little bit less lower dose compared to the conventional trough level dosing. So there is a meta-analysis evaluating two studies comparing the AUC versus trough guided monitoring. It says AKI was significantly lower in AUC monitoring group compared to trough. So this is the main important point. AKI was significantly lower in AUC. That's why new guidelines recommend AUC monitoring. And almost a 300% increased risk of nephrotoxicity if the trough level is more than 15 mics per ml. So trough level monitoring has an increased risk of nephrotoxicity. And for AUC monitoring, there is 55 to 65 decreased risk of nephrotoxicity. The limitation is, as I already said, if the vancomycin MIC is more than 1 mg per liter, the probability of achieving the target MIC is 400 to 600. So if the MIC is high, that means more concentration is required to kill the bacteria. So in that case, the target AUC bar MIC is difficult to achieve. This is the limitation for AUC based TDM. So this is the target. I already said about it, and the 2020 SHB, IDSA, SIDP, and these consensus guidelines, they recommend AUC and MIC guideline, AUC monitoring over trough monitoring. So there are two methods for vancomycin AUC calculation. One is Bayesian model calculator, and the other one is trapezoidal model or first order equation model calculator. So for Bayesian model calculation for AUC, only one vancomycin level is required. There is no need of peak and trough, only one level. Like usually we go for trough. This level will give you the AUC. There is some websites you can calculate the AUC for vancomycin based on this Bayesian model. The target is same, 400 to 600. These are the website I said. You can use ClinCalc. This is the free access, and you can use it for Bayesian model calculation and check the AUC and check if it is within the 400 to 600 range. So as you know that if it is less than 400, we have to increase the dose or decrease the dosing interval. If it is more than 600, we have to think about decreasing the dose or increasing the dosing interval. So this is the ClinCalc website. Here you can add all the inpatient information and the creatinine level. If you have a second level, you can add that also. But as I said, Bayesian method, you need only one level. That in that way you can calculate the AUC. The second one is trapezoidal model or first order equation model calculation. So this one, in this method, we need peak level and trough level. So usually we go for steady state once, like after 3 dose or fourth dose, the usually the steady state will be achieved. So in that case, we will check for the peak and trough. The previous method, we will go for only one sample. Here we are going for two level for calculating the AUC. The most commonly used AUC calculator is from the Sanford. It is paid one. You can access the Sanford mobile application. It is very easy to use, and you can enter the patient information and the trough level, peak level. Then you will get the answer for the AUC. Then according to that, you will modify the dose. This Excel calculator, this is like one of my friend created this one. This is free access, and you can enter all the details here, and you will get the AUC. Based on that, you can modify the dose. So regarding subsequent monitoring, once weekly monitoring is recommended for both AUC and trough guided dosing if the vancomycin is given for prolonged duration or a patient is increased risk of nephrotoxicity. More frequent monitoring is recommended if patient is hemodynamically unstable and if there is any rapid change in the renal function. Apart from the AUC or trough monitoring, we have to check the serum creatinine, urine output, etc. So now we will discuss two clinical scenarios for vancomycin dosing. So this is the first clinical scenario. A 48-year-old man, a male patient, was admitted in hospital with communicable acquired pneumonia, and he has grown MRSA in the sputum. His renal parameters are within the normal range, and he is currently receiving vancomycin 1 gram Q12 hourly for the MRSA. It is usually like 1 gram should be infused over at least 100 minutes. Here patient is getting over 2 hours. So peak sample is withdrawn 1 hour after the third dose of infusion, and the trough is drawn 30 minutes before the fourth dose. So the peak is reported as 22 and the trough is 8 mg per ml. So calculate the AUC and recommend a new dosing interval if appropriate. So this is the clinical case. All the informations are given. So we have to calculate. How we will calculate? We will go for the like Excel calculator or the Sanford. These are the information. Dose is 1 gram Q12 hourly, infusion over 2 hours. Then peak level we got from the lab is 22 and the trough level is 8. So all this information we will give input to the Sanford. Here, this is a screenshot from the Sanford AUC calculator. So here, from the case, the dose is 1000 milligram or 1 gram, Q12 hourly. Duration of infusion is 2 hours, and the peak concentration we got is 22. Then the time, this is very important, time from start of infusion to measurement of peak concentration. So the start of infusion, we are giving over 2 hours infusion. So we have to wait 1 hour after finishing the infusion to check the peak concentration. So here you can see it will be 2 hour infusion and 1 hour we will wait before withdrawing the sample. So 3 hours. Then the measured vancomycin trough concentration we will get from the lab. We got from the lab, it is 8. Then the another important thing is time from start of infusion to measurement of trough concentration. Like already we started and we withdraw 30 minutes before the next dose. Once we give the dose, we will wait because the dosing interval is Q12 hour. We will give the next dose at 12 hour after. So the sample will be withdrawn 30 minutes prior to the next dose. So the time from start of infusion to measurement of trough concentration is 11.5 hours. So all this timing should be recorded in the patient profile, and the data should be added to the mobile application appropriately. Then it will give you the answer. The result here, it is showing AUC is 354. So we know that the target AUC is 400 to 600. So that here the 354 means this is below the target range. That means patient is not getting adequate dose. So we have to think about the new dosing regimen. So the same mobile application will help you to calculate the new dosing regimen. So I give like now we are giving 1 gram. So I increase to 1250 and same dosing interval Q12 hourly. I didn't change the interval. Then infusion new duration of infusion 2 hours because it will be 10 mg per minute only. So we can go for the calculation. It will give you the new predicted AUC. the mobile app will tell you this one. So if we increase the dose to 1250, the predicted AUC will be 443. That is within the required range. So we can confidently recommend to the physician to go for 1250 to increase the dose to get the appropriate response for the antibiotic. So this is the answer. Calculated AUC is 354. Then we recommend to modify to 1250 Q12 hourly. This is the second clinical scenario. A 55-year-old male patient receive vancomycin 1 gram intravenously every 24 hours and has a trough concentration obtained 30 minutes before the third dose. Here only one level we have, and the trough concentration is 6 mg per ml. With an estimated vancomycin 24 AUC, like we calculate already the AUC is given. We don't have to calculate the AUC. It is 246. Which regimen is best for this patient if the goal AUC is 402, 600. So already the AUC is below the goal AUC, is 246, and the dose patient is getting is 1 gram once daily only. So the answer is there are multiple options for the answer. So the answer is vancomycin is following the linear pharmacokinetics. That means if there is no changes in the clearance or volume or other patient pharmacokinetic or pharmacodynamic variabilities, in that case, whatever the dose we increase, it will give you adequate concentration in the blood. So in this case, double the dose will give you the double AUC. So already we are giving 1000 milligram over 24 hours. It is giving 246 AUC only. So just a double. So if you give 1000 milligram instead of Q24 hours, if you give Q12 hours, that means twice daily, it will give you just the double of the AUC. That means 246 to 492. So it will be in the target range. This is how we modify the dose. This is in case of there is no changes in the clearance or volume. That's all about vancomycin. These are some other antibiotics. Usually we are going for TDM, but some facility will have the option for doing TDM for this antibiotic. In our facility, we don't have. For example, ticoplanin, there is target trough, and for daptomycin, chloramphenicol, itraconazole, posaconazole, voriconazole, isoconazole, and all these kind of antibiotics also some hospitals are doing trough level to optimize the dosing regimen. The important thing I wish to tell you is that if you are going to initiate or already conducting a therapeutic drug monitoring for aminoglycoside or vancomycin or any other antibiotic, you have to prepare your own guideline for your hospital based on the scope of service and based on your requirement to pass the information to the physician and the nurse. And this guideline will help you whenever you need a double check, and it will help you to make the things happen appropriately, because TDM is not very easy to do, because in each step a clinical pharmacist or pharmacist has to monitor. Then only we will get the appropriate results. So I strongly recommend to build your own hospital guideline for the TDM. So these are the references I used for preparing this presentation. If you have any questions regarding my presentation or the TDM, you can ask. Thank you for listening.
Thank you so much, Dr. Ajmal. Therapeutic drug monitoring is something we struggled to tackle, and I think you made it really easy. Thank you so much for that.
Thank you, Dr. Alia.
So yeah, we have some couple of questions. I'll go ahead with it.
Yeah, sure, we can go.
Okay, first question, I'll divide it into two. First question is, do oral vancomycin and surgical prophylaxis orders require therapeutic drug monitoring?
Very good question. For answering the question is like the oral vancomycin usually does not absorb systemically. It will be having a local effect in the intestine. Usually we are giving for the Clostridium difficile infection. So since it is not reaching the bloodstream, it will not be having any toxic effect for the kidney usually. So in that case, we don't have to monitor TDM for oral vancomycin. And the second question is regarding the preoperative or surgical prophylaxis. In that case, also we usually don't recommend to go for AUC monitoring, because a preoperative dose will be only one dose or maximum 24 hours in certain surgeries. In that case, also no need to monitor TDM, AUC or trough level. But if like postoperatively, if there is any infection is happened or any infection is suspected and continuing on treatment, they can keep on monitoring AUC or trough level based on the clinical condition.
Okay. Next part of the question is, apart from the paid app like Sanford for AOC calculator, are there any free websites that we can access or portals for AOC calculations?
Yeah, very good question. As I already mentioned, there is a ClinCalc website. They are providing free access. You can easily access to that and input your patient information, and then you will get the AUC result. And also there is some Excel calculator prepared. I already shared one screenshot. I can from the slides you can get the access, or I can share it with you if you contact me. From using that Excel calculator also, you can freely access to AUC calculation.
Okay. Next question is, any special consideration for vancomycin therapeutic drug monitoring in pediatric populations?
Yeah, that's a really good question. We mainly focus in the presentation on adult patients. So for pediatric, usually we go for the dosing 45 to 60 milligram per kilogram per day. So the dosing interval will be different from the adult, like Q6 hourly or sometimes Q8 hourly also. So in order to reach the steady state, we will wait at least for fifth dose. For adult, we are focusing on the fourth dose, like after the third dose or just before the fourth dose. For pediatric, the difference is that we will wait to finish the fourth dose. We will monitor the peak level after the fourth dose. Instead of third dose, we will monitor after the fourth dose. Then the trough level we will monitor before the fifth dose, because we are waiting to reach the steady state concentration. And apart from this, the target AUC is same as adult, 400 to 600. And already I discussed the infusion. We have to take care of the infusion. At least over 1 hour, we have to infuse the vancomycin to avoid any kind of reactions. And there is another point I have to add. There is a new update in all this Sanford and everything. Like if we are going for AUC monitoring for vancomycin, we have to check the peak first. Like after the third dose, we check the peak first. Then just before the fourth dose, we have to check the trough level. This is how all the new guidelines. This is a recent change. If we go for the trough level first and peak level after the next dose, when we enter the information in the like Sanford mobile app and all, it will not give you the correct answer. So keep in mind that we have to check the peak first after the third dose, then before the fourth dose, like during the same dosing, like after the third dose and before the fourth dose. This is how we have to do.
Okay. Last question. Can you explain more about vancomycin desensitization?
Vancomycin desensitization, like if there is any history of allergy or any kind of vancomycin reaction recently happened, usually the vancomycin allergy is infusion related, not true allergic reactions. Like we have to check how the patient was received the antibiotic before previous dose, because if it is given too fast, it will give you like infusion reaction. In that case, slowing down the infusion will solve the issue. No need of any desensitization. Only the just slowing down the infusion will solve the issue. And if there is any true allergic reaction, I think I believe skin we can do skin test for desensitization as well.
Okay, I think that's it. Participants, if you have any more questions, feel free to reach us at fcpaofficial@gmail.com. Thank you so much, Dr. Ajmal. Thank you for taking your time to participate in this.
Thank you, Dr.
I
Alia.
just want to tell to the participants that our speakers have worked really hard for all the basic modules. So they make best use of it and go back to our website. Everything is free. You can download everything at FCPI website. And if you have any questions or or queries, you can always reach us out. And we have our, I'd like to go through again about our conferences. We have the CP Conclave organized by the Amrita College in November, and we have CP Summit in Pune again in November, and we have our ID Congress 2024 organized by ICRA in January 2024. Thank you so much.